Welcome to part 3 of the Improving the Early Identification and Treatment of Patients with Chronic Kidney Disease webinar recording. This webinar was recorded on the 26th of August 2021.
So, thank you, Paola and Bohumil, for the interesting presentations. I thought it brought some new insights for many of us. I just recognize the first question, which is coming from Jean-Pierre Jacquet from France. He is asking, and maybe the question goes to Paola, how many patients without diabetes I must treat with SGLT2 to avoid renal failure or death? Are you able to say something about this?
At the moment, I don't have in mind exactly the number needed to treat. That is what he's referring to. Maybe we can go back to the slides. I'm not sure that that number is there, but the number needed to treat is quite low. If I don't recollect wrongly, it's around 25, 30 patients to be treated for the 2.5 years of the duration of the trial in order to avoid one progression towards end stage.
Yes.
So it's a very low number.
Yeah, but the number needed to treat, you're talking as about patients with diabetes, correct?
No, I'm talking without.
Without, okay.
Yeah, in fact, if you look at the DAPA-CKD results, it is not significant, but it looks like the beneficial effect is more in patients without diabetes, with a relative risk reduction of 50%, while it was around 36 in the diabetic population. So it is even stronger in the non-diabetic. And to my knowledge, the only data that I've seen published so far, because there was a large subset of patients with IgA nephropathy, the data are quite impressive, very strong reduction in risk.
Okay, thank you so far, Paola. Joseph Villaseca from Spain is asking, he's thanking for the excellent presentation, but his question is it possible to prescribe SGLT2 to non-diabetic patients in any European country? What to do to overcome the current national regulations? And I would like to ask the question, since we have a geographically very broad audience, are all GPs able to prescribe SGLT2 inhibitors to diabetic patients as we are in Germany or not?
Well, if I can start, first of all, in Italy, the GPs are not allowed to prescribe SGLT2 inhibitors. I think is one of the few countries in Europe where this is the case. SGLT2 inhibitors are very easy to use, but we are a poor country, and I think that to limit the cost, all the, let's say, new or newer agents, including DPP4 inhibitors, they are not new at all, GLP-1 and SGLT2, you need to have a diabetologist filling a sort of therapeutic plan, and then the GP can prescribe. So there are a lot of limitations. When it comes, the question was about non-diabetic patients, correct?
Yes, correct.
And for now, we don't have an indication yet. So if you decide to use an SGLT2 inhibitor in a patient with chronic kidney disease without diabetes, it will be off-label. I think that very soon there will be the indication, but not yet.
Yeah, thank you. This is similar in Germany.
Yeah.
Yeah. Bohumil, how is it in the Czech Republic?
In the Czech Republic, GPs are limited in diabetic care only for patient type 2 diabetes, and they have to keep the target below 7%, 53 millimole, only with use of 3 types of antidiabetic agent, biguanide, sulfonylurea, and incretins, but not SGLT2. So in case the patient needs SGLT2, for example, or GLP-1 receptor agonist, we have to refer patient to diabetic. And I think it's not possible to prescribe SGLTs, glyphosate, to non-diabetic patients.
Okay. And Baruch from Israel is asking, would you recommend SGLT2 in diabetes mellitus patients as a first-line therapy?
According to recommendation of Primary Care Diabetes Europe, as Professor Fioretto just presented, it's recommended for patients with a CKD, with a chronic kidney disease and diabetes.
Yeah.
But that in also the cardiologist had a similar approach, suggesting that in patients with very high cardiovascular disease, we should start SGLT2 inhibitors with metformin or with or without metformin. The European Association for the Study of Diabetes is more, how can I say, careful. I mean, still going with metformin, but now in the general diabetic population. So metformin is first, but now in patients with chronic kidney disease who are drug naive, it is recommended to start with metformin and SGLT2 inhibitors, regardless of the glycemic control. So the idea is that SGLT2 inhibitors should be used not necessarily to lower glucose, but to improve outcomes in patients with heart failure, where is already on the label also in the non-diabetics, and for chronic kidney disease. Keep in mind that when patients have a impaired GFR, such as less than 45, the efficacy of SGLT2 inhibitors in improving glycemia is very, very small. So if you start that therapy, don't expect to have an improvement in glycemia. You give that therapy to save the kidney and to save the heart.
Okay. Yeah, Gela Santa, also from Germany, has a very important remark. She's asking and saying, not just saying, when somebody has a chronic heart failure and CKD, you can prescribe SGLT2 inhibitors, even if there is no diabetes in Germany. So there are some ways and some approaches, and maybe we should try to broaden this and check how the situation is in other European countries.
In Italy, we are waiting for that approval in the non-diabetic population with heart failure, because there are 2 studies with heart failure and reduced ejection fraction proving that. And so our agency is taking the recommendations of FDA and EMA. So hopefully soon we will be able to. I mean, we can use them. The question is reimbursement. So soon we will have a reimbursement.
Yeah. Turinda is asking, it appears SGLT2 work by increasing ketone bodies in the body. Could we encourage increased intake of ketone bodies to improve renal function? Paola, do you think this would be a way?
This is a very provocative question. When you use SGLT2 inhibitors, you have a very tiny increase in the levels of ketone bodies, especially beta-hydroxybutyrate. And in fact, we know that when we use these SGLT2 inhibitors in patients with type 1 diabetes, the risk of diabetic ketoacidosis is increasing if we are not very careful. So some authors have hypothesized that this tiny increase in ketone bodies can be beneficial in the metabolism of the failing heart and the failing kidney. I personally think that the contribution of the slightly increased ketone body levels to the nephro and cardioprotective effects is minimal. I would not encourage a patient who is on SGLT2 inhibitor to do a ketogenic diet to lose weight. I don't think that's a great idea. And personally, I'm not really convinced that improving ketones is so beneficial for your heart and your kidney. It doesn't hurt. It may help a little bit, but there are other mechanisms that are more likely to be responsible for these beneficial effects.
Thank you. José Miguel Albuano from Spain thanks you for the 2 excellent presentations and asks, how do you think the CKD will be in the next 10 years, Bohumil? What's your opinion? What do you think? What will happen?
If I can
You go first.
if I can start, I think that you will say the gold words, but from my point of view, it looks very optimistic with this new neuroprotective treatment, also for other causes of chronic kidney disease. There is some light in the tunnel. So I think that if we will cooperate well with the specialist and will early introduce this possibility to patients, so I think that we can improve the outcomes. What do you mean, Professor?
I am also very optimistic, but I always like to see the data. Because you need to remember, with ACE inhibitors and ARBs, the idea was no more dialysis, right? But if we look at the curves, there is that interesting study published in New England Journal of Medicine years ago, observational, looking at over the time, the rate of the chronic diabetic complications, a decrease in amputations, decrease in myocardial infarction, decrease in stroke, but no decrease in end-stage renal disease. So it's a very difficult complication to really target, but the results of these studies are very promising. And I think that our goal, though, should be more than treating patients with CKD, preventing CKD. And I think there is evidence from the real-world studies and all the long cardiovascular outcome trials that SGLT2 inhibitors are excellent also in primary prevention of diabetic kidney disease.
Yeah, I can agree to this. Maybe GPs are always optimistic, but we just are working on a simulation study with approximately 10 million hypothetic from the population, and asking whether a screening for CKD could be efficient, and what would happen based on the available evidence to certain endpoints, especially dialysis and dialysis-related costs. And it seems very promising. So I would strongly support, Paola and Bohumil, what you said. And of course, from my perspective, maybe our GP perspective, early detection is a very important point. And Samuel is asking, what kind of criteria would you recommend for GPs to improve early diagnosis of CKD? Maybe, Bohumil, you can refer back to what you said in the presentation.
Yes, I think it's very important, especially to control patients with hypertension, diabetes, and cardiovascular diseases, and test as recommended once a year or even more often for the two basic measurement, the estimated glomerular filtration rate and urinary albumin to creatinine ratio.
And I just thought what I was doing in general practice or in my practice, Bohumil, when I've seen that you recommend the further laboratory examinations. Could you tell me something? It's kind of subjective. How often do you offer the determination of C3 or C4 and such very special laboratory values?
Almost never. Thank you for this question. Almost never. But this is recommended for the more specific examination, and I suppose that this examination would be done by specialists if needed. I don't know if Professor Fioretto uses it.
I think this leads to the diagnosis of non-diabetic kidney disease in a patient with diabetes. I mean, there are some patients who have other chronic kidney diseases, and by the way, they also have diabetes. Now, that is very important for the GPs, because when do you suspect that a patient may have another chronic kidney disease, not due to diabetes? And usually what is said is that if, of course, in type 1 diabetes is easier to know when the onset of the disease is, but if you have a very short duration of diabetes, of course, in type 2 we don't know. So duration is not really a criteria. You should suspect a non-diabetic kidney disease. So duration doesn't work. A lot of patients already have chronic kidney disease when you diagnose type 2 diabetes. The other thing is to look at the eye. If the patient has a very fast progression of kidney disease without any diabetic retinopathy, you should consider other chronic kidney diseases that may benefit from specific therapies. So usually when you have a fast development of nephrotic range proteinuria or a fast decline of GFR in absence of diabetic retinopathy, you should consider non-diabetic renal disease, and then you can, of course, do what Bohumil suggested, including ultrasound, especially comes to mind polycystic kidney disease or other, and then send the patient to the nephrologist. But you should never consider that all patients with type 2 diabetes, with chronic kidney disease and diabetes have diabetic nephropathy.
Okay.
They may have something else.
Yeah, so thank you for clarification regarding this issue. And for sure we should think about it and think what we are doing in the practice and seeing patients. Joseph Villaseca added a comment. A colleague pointed out that dapagliflozin was approved in the EU on 2.5 weeks ago to treat CKD. It's very new, so we might be not aware. Dapagliflozin is no longer off-label. I wonder when we'll be informed at the national level. So yeah, maybe Joseph, you're right. Maybe we will be late informed, maybe on purpose, maybe not. But we should have it in mind and pay attention to this.
FDA, yeah. This is US, correct? Yeah.
But he did not say, he did say in the EU, he did not say FDA. In the comments. So maybe we should check on ourselves and find out what we could do on the national level. I think one of the last questions from Özlem Gökdemir. What do you think about the link between new onset of diabetes after and or during COVID-19? Do you think there is a relation?
I'm sorry, what was the question?
What do you think about a possible link between new onset of diabetes mellitus after and or during COVID-19 infection?
Bohumil, you want to start or I go?
This time I have nothing to say about it. I would be happy.
Unfortunately, I had to do a lot of working internal medicine with COVID. And as you know, in the first wave, Italy was heavily affected by COVID. So we, of course, looked at the relationship between new onset diabetes, and it looks like, one question is if there is a relationship between diabetes or hyperglycemia and prognosis, meaning death, basically, or the need for reanimation. And in fact, it's not that strong, but is especially the newly diagnosed patients with diabetes newly diagnosed that have a worse prognosis. If you ask me if I think that COVID may cause or that I have no idea, these days it's also a little bit difficult to dissect because we start now steroids right away when patients are admitted for COVID-19 pneumonia. But there is plenty of literature on diabetes and COVID, especially on the influence of diabetes on death and outcomes. And there is an influence, especially in those with newly diagnosed.
Okay, thank you, Paola, for letting us know. So Mehmet Ungan is asking, and I kept this question nearly to the end. what are the top 3 messages for our European family doctors from the 2 presentations? So it would be nice if you could puzzle it together and point.
If I can start as a primary care physician, because the patient comes first to us, so I feel that I should start. So from my point of view, and I refer back to my presentation, is to think about the possibility of development of chronic kidney disease, especially in diabetic patients, and use the recommendation of early identification using this two measurement as I recommended, and do it systematically at least once a year to early identify the possible renal impairment.
I agree with Bohumil. If I had to pick one message only, I mean, what's the most important thing to diagnose? Screening, early diagnosis, that is the most important thing. And if you look at the data from diabetes centers, not GPs, of course, creatinine you always do, right? But despite the fact that you do it, you don't look at eGFR. Or even if you look and the GFR is 50, well, not so bad. So you really need to keep in mind the risk, renal and cardiovascular, of your patient. Where we are really missing is the measurements of albumin creatinine ratio. It's amazing that despite the fact that it's simple, we don't need timed urinary collection, still we don't do it that frequently, and it's not expensive. So first message is screening and early diagnosis. Second message is therapy. Therapy, we have treatment. We need to use RAS inhibition, no question. If you have a problem with hyperkalemia, don't be afraid. You can use a diuretic and get rid of hyperkalemia. Don't stop the ACE inhibitor ARB. And then definitely now we have SGLT2 inhibitors. And I think that we have to use them because the efficacy is proven. No question. So first, screening and diagnosis. Second, proper treatment with what the current guidelines, and don't forget lipids, and don't forget to ask your patient to stop smoking. Smoking is a very potent progression promoter of diabetic kidney disease, of any chronic kidney disease, more diabetes. So is all the package, but now in that package we have very potent drugs. We need to use them.
If I can add one more message, what we say to our GPs in the Czech Republic who can't prescribe CGLT2 inhibitors, that even if they can't prescribe it, they should refer these patients to get them this treatment available.
Yeah. Okay. So thank you very much for summing up. Also, Bao from Israel and other colleagues mentioned, and thank for the excellent session, which brought great insights. Again, I would advise you that the session will be available afterwards through the Wonka Europe podcasts and also in translated version. Bao mentioned he's looking forward for more webinars and for a very broad audience again. And the third webinar in the RAW, and I'm quite sure that there will be more webinars in the future, will be announced through Wonka Europe. And we all from Wonka Europe would be happy to see you again. And I would like to thank you all for attending this session and for asking interesting questions. And especially, I would like to thank Professor Fioretto and Professor Seifert for giving these excellent presentations and raising some questions and enhancing our knowledge on the topic. Thank you very much. Bye-bye to everyone.
Thank you very much for involving me in this important program, I think, because, as I said, if we want to change the numbers, to change prognosis, the GPs is a key role. And these agents are easy to use. So I hope that very soon all GPs in Europe will be able to use these agents with the proper training, but it's easy, without having us specialists, being the only ones to be allowed to prescribe. Again, this is only for economical reasons, to save money. It's not because the GPs cannot use them.
Yeah. Thank you.
Thank you.
Bye-bye.
Bye-bye.
Bye-bye. Thank you.